that hits the headlines, but something that's remarkably common and actually reasonably resource intensive. And I think it's a really timely topic as we are beginning to address some of these issues, particularly from a system area. As far as disclosures, I have no conflicts of interest, not yet anyway, that I know of. We'll get there. For those outside of Atrium Health itself, we were originally Charlotte Memorial Hospital, which was established in 1940. We are now obviously the region's level 1 trauma center. We are obviously a tertiary care center with many of the typical tertiary needs: cardiac surgery, transplant surgery, neurosurgical interventions, etc. We are just outside uptown Charlotte. And this is a night view, particularly of the Levine Children's Hospital side of things. And we are the F.H. Sammy Ross Jr. Trauma Center. And we are the center for our region. So as an outline, we'll just do our brief introduction here. We'll discuss our trauma system and how it's worked out through the state. We'll talk a little bit about the epidemiology of brain injuries. Obviously, it'll be very important to define brain injuries as well. Let's look at some outcomes and then the strategies for the right place, right time. And that's a quote right out of the resource manual for the care of the injured patients put out by the American College of Surgeons, which is basically the cookbook or the instruction manual to become a trauma center. And then we'll talk about some follow-up issues for brain injuries and have hopefully some question and answers. So we are part of the Metrolina Trauma Advisory Committee. And basically, the state of North Carolina has been divided up into 8 regions. And these are based around each of the trauma centers. Level 1 or level 2, which are full service trauma centers. And that allows for some of the healthcare resources. So this is not just the trauma designations, but truly the disaster management for the state of North Carolina as well. And again, you can see us in the middle and the bottom in Mecklenburg County here, and you can see the surrounding even level 3 hospitals that we have in our region that are part of our system as well. And we do extend down into South Carolina and another level 3 center at the Piedmont Medical Center in Rock Hill is really within our system. So one of the things that I think it's important to define some of the trauma centers. We talked about the level 1, level 2s. The level 3s are serve communities that may not have direct access to level 1 or 2 centers. That can provide prompt assessment of resuscitation, stabilization, and even resuscitation and surgery. But there may be some limitations on some of their resources. And obviously, therefore, a participation in larger regional trauma center system is essential. And one of those regional resource needs is the presence of neurosurgical teams and a neurosurgical response, which are not required for a level 3 center. So when we talk about a level 1 verified trauma center, obviously immediate neurosurgical response is required. Here you can see a CT of a very large subdural. And this is the operative finding of the subdural, the clot right under the dura itself. And obviously you must have a very rapid trauma response and neurosurgical response to be able to deal with these. Also, not all brain injuries are surgical or decompressive in nature. There's a lot of issues with brain injuries that may or are medically related, and supportive care, whether that's mechanical ventilation or even intracranial pressure monitoring. We can see a CT scan here of a number of intracerebral contusions, a small subdural as well. And the patient on the right is in the intensive care unit with an ICP monitor being managed by an intensive care critical care team as well. Not all brain injuries are that severe. And in fact, the vast majority of traumatic brain injuries are what we call minor and even moderate, that may not have any CT findings of an injury itself. And here's basically a plain CT scan with no evidence of findings, but these patients may have altered mental status and underlying neurologic injury. So from an epidemiological perspective, there are about 500,000 traumatic brain injuries. 10% die prior to the hospital, And of those, 80% of them, or the vast majority, are actually what we call mild. And that means their Glasgow Coma score is reasonably or close to normal, GCS of 14 or 15. But even a GCS of 15 doesn't necessarily mean normal. You can have some short-term cognitive issues that play into this, and we'll expand into this and the importance of that. Obviously, moderate is a higher level or worsening Glasgow Coma score, as well as the severe traumatic brain injuries as well, which require a much more intensive neurosurgical and ICU presence. Now, our trauma center has been involved in this for a number of years. This is a paper that's probably going on 12 years old that was performed here. And we looked purely at the utility of neurosurgical consultation for a mild traumatic brain injury. And initially, mild brain injuries at the time were defined as a GCS of 14, 15. So we wanted to look at our experience and what the natural history was of these particular patients. And as a focus, we excluded patients with normal CT scans, so the patients who were quote unquote concussive, but we looked at the mild brain injuries that actually had abnormal CT scans. And I think that was an important point of this. And the patient demographics are the typical trauma patients here. Many of them have associated injuries, either orthopedics, injuries, abdominal injuries, and particularly multi-system. The majority of these actually had some level of amnesia or a incidence of loss of consciousness. Now, the CT scan findings in these patients, even in the GCS of 15, again, we looked at all patients with positive scans. The majority of these injuries were small contusions, less than 5 millimeters, or traumatic subarachnoid hemorrhage. And there were much smaller amounts of patients with either a small subdural or epidural hematoma. And those are defined particularly that many of these were actually remarkably small. Now, in our practice, we have routinely, or have been routinely in the past, performing repeat CT scans to again try to get an idea what the natural history of these patients are. And what we see here, that the vast majority, 84% in our study, those patients had no change in the CT scan. There was 9% showed quote improvement in the CT scan, and 7% showed worsening. And I'd caution you what worsening means. The majority of these patients did not have huge expanding subdural hematomas, et cetera, but very much like a bruise that's the size of a quarter today, and tomorrow it's the size of a 50-cent piece. So there may be some what we call expected evolution of the radiographic findings in these patients. So when we looked at and narrowed down these outcomes of worsened CT scan patients, 4 had a slight decrease in their GCS 15 to 14. These were really remarkably self-limited. 1 patient actually received a dose of mannitol per neurosurgery for an area of, quote, focal edema that was seen on the CT scan. And notably, there was no intracranial pressure monitoring for this. And that patient did not have any change in his neurologic status. And overall, despite these worsened CT scans, none of these patients required any neurosurgical or interventional neurosurgical intervention at that time. So the question for us really became, do we really need neurosurgical consultation in the vast majority of these patients? Our conclusion at the time was, in reality, no. Their presence is obviously very helpful and beneficial. If there is further deterioration, then we can implement the neurosurgical evaluation at that point. But for the patients, particularly with a GCS of 15, even with abnormal CT scan findings, the fundamental neurologic examinations can be performed by non-neurosurgical staff, and part of those protocols are typically done by even the bedside nurses as well. And if we looked at the time of this study, we were looking at a fairly significant improvement in decrease in cost consultations and subsequent visits, particularly for the neurosurgical part of this. So in these patients, we had 1,400 patients with a mild traumatic brain injury. 538 of these had a length of stay of 1 day. Of the 690 patients transferred from outside centers with these mild traumatic brain injury, a little less than half of them were discharged with a length of stay of approximately 1 day. Now, some of the issues that you have to play into this regarding what were those patients had longer length of stays, many of those essentially end up with social issues, whether it's transportation, because some of these patients, particularly for the out-of-town patients, have transport and to get back to their home, and then they also have other potential injuries involved. As recall in the earlier slide, many of these patients had other concomitant injuries. But again, it wasn't the brain injury in this mild group that actually held some things. So we have a very close relationship with the neurosurgical team. This is Dr. Joe Bernard, who's been working with us, particularly with our brain injury guidelines. And I know Dr. Miles spoke about this just a few months back. And they are working with some of the brain injury guidelines, not just related to trauma injuries, but other neurosurgical events such as acute subdural or non-traumatic subdurals and intracranial bleeds as well. So further on, a few years later, and this is just a year-old publication, but a several-year project that we performed here. And this was, again, trying to look at what we can do to improve our appropriate triage of these patients. So if we go back and look at those 690 minor brain injury patients that were transferred here purely because of neurosurgical coverage, we didn't really need neurosurgery in those patients. So the question is, can we define that group of patients with a, quote, mild traumatic brain injury that really don't need to come here? And those are resource savings, not just for the healthcare system, but the families as well, because they have transport issues and commuting issues along the way. This is a study we performed a few years ago, published in the American Journal of Emergency Medicine. And this was with our colleagues in Neurosurgical, who helped us define some radiologic findings that kind of go along with the brain injury guidelines in defining what is a level of a brain injury. Because when we talk about the minor or mild versus moderate versus severe traumatic brain injuries, much of this is really based on the Glasgow Coma score. And we know that within a Glasgow Coma score, you can have actually a fairly wide range of outcomes in those patients. And our question was, could we further define this? So we looked at the patients, and we actually included the GCS of 13 in this group. The difference of a GCS of 13 and 14 can be somewhat subjective. So we just extended this a little further out to get a better idea with that. And then we looked at the patients for this group, and particularly that were discharged early. So we obviously knew earlier that minor traumatic brain injuries overall had good outcomes. Patients were frequently transferred, and neurosurgical interventions were rare. So what could we do to better take care of these patients and be a little bit more efficient with our time and our resources as well? And along with this, as I just stated, there's some limited understanding of the neurosurgical intervention related to the CT scans. So we went back to look at some novel CT criteria. We'll get to that in a second, and then stratify the patient's risk for neurosurgical intervention. So this was a retrospective review from 2014 to 2016. Again, we included GCS of 13 in this group as well. Obviously, we had to have a CT scan available, and then we looked at neurosurgical intervention and got some input on potential transfer costs, which obviously are somewhat limited. So these CT scan criteria that were defined here by our neurosurgical team categorizes a category A versus category B. And I don't need to read them here, but if you look at the bottom, the qualification for a mild traumatic brain injury, they could not have more than 2 of the category A lesions. If they were considered if they had more than 2 category A lesions, they were considered a more severe brain injury. And if you had any of the category B injuries, you were automatically outside of that, quote, minor. So not only did we take the clinical aspects of the GCS, but we looked at the radiologic findings on these patients as well. Overall, 2,100 patients, 1,400 of them categorized in our minor group, or that category A, versus 678 in the severe group. Obviously, some of the injury severity scores make sense, length of stay, all of this stuff makes sense here. What was interesting, however, with the anticoagulation and antiplatelet therapy for each group was really no different in regards to their initial presentation. Obviously, the CT scans by definition were going to be worse in the severe brain injured groups. And again, to be a category B or to get out of category A, you could not have more than 2 category A findings. So a patient, for example, that had an intraparenchymal contusion, an intraventricular hemorrhage, and a small subdural automatically was dropped into the moved over to the severe group. We looked at some of the admission services for this related to these minor injuries. Obviously, the more severe groups tended to either be the neurosurgical service or the trauma service. Obviously, if it was simply isolated, it went to it had a greater chance to go to neurosurgery, but frequently these would go to the trauma service because we always see those patients. And again, very similarly, 1,400 patients, length of stay of about a third of these, about 1 day. And again, these are the minor abrasions. And even some of the patients with the major injuries had some relatively short length of stays as well. Transfer cost, 63% of the patients that were transferred came by air. Obviously, that's a very resource intensive and expensive play here. 90% of these came by ground. None of those patients actually had any neurosurgical intervention. Estimated transport per ground is about $5,800 per transport at the time of this study. Came out to over $250,000 and $700 per ground, just under $500,000. So the total cost for transferring these patients, just for the transfer cost, was $800,000 over this time period in a group of patients that we are now feeling that probably don't need to be at the level 1 trauma center. Again, some of our costs here overall and with the patients, even these are the patients with only a length of stay of 1. So again, a length of stay of 1, 23 patients came here by helicopter and were out the door in a day. So you can see there's a lot of very expensive and again, high resource utilization for the patient and their families as well. And the families, particularly the ones out of town, have to come into town. They have to travel. They have to commute. They have hotel issues, work issues, et cetera. You can see how this really becomes much broader than just the expenses that we see in the hospital bill. So our finding was basically that some novel CT criteria actually much better define these, even the mild traumatic brain injuries, and also can identify those patients that can be managed without transfer. And that obviously lessens the burden on the trauma system or the trauma centers, and all of the trauma centers are getting filled to their brim at this moment, and obviously the resource and inconvenience to patients and families as well. So we are beginning to develop some criteria. We've had some criteria in the past to actually avoid delays in transfer. Now we're beginning to redefine some of these so we can help some of the other outlying centers take care for these patients without feeling that they need to come to the trauma center. And obviously there's a big educational component to this as well. So what are our protocols? We're beginning to work on this. I think we need to have some very well-defined guidelines for the neurologic checks for these patients that aren't coming us, and that defined indications for repeat scan, and obviously appropriate physician and provider overlook. This is Bill Joseph. Is out in Arizona. He has done very similar work to what we've done here, and has really defined the brain injury guidelines from his part of the country as well. And as we're kind of overlapping this, we can kind of see there's a lot of similarities, and he's been doing a lot of work along with this. And we are actually communicating with him right now as we are beginning some of our endeavors within the MTAC region regarding minimal brain injuries as well. So he put together some very similar, and if you look at the CT findings or the radiologic findings, they're remarkably similar to our brain injury guidelines as well. And with this, he divides these up into the big 1, big 2, and big 3. And primarily, these are frequently based on the radiologic findings of those patients. Even the presence of loss of consciousness is a yes or no across the board. So the event of loss of consciousness does not change the brain injury guidelines from one to another, and all of the even neurologic criteria can play across the board with these patients. So in his study, they did a very similar situation where, but they, for the big one category, they only observed this patients for 6 hours without neurosurgical consultation and without repeat head CT scan. And if you can come back up, there were even patients with some notable findings, even a small subdural hematoma. If the patient did not change, or intraparenchymal hemorrhage, the patient did not change or get worse in the 6-hour period, they were discharged. And they were obviously discharged with appropriate, what we call head injury instructions or a head sheet and appropriate follow-up. But here's some of his the pre-big and post-big for this patient population here. And you can see that the outcomes really didn't change too much regarding patients deteriorating from these injuries with that level of brain injury. So when you look at the big one analysis as well, again, just looking at the minor injuries with the minimal radiologic findings, but potentially present radiologic findings, neurosurgical consultation was much higher beforehand, much less later. Hospitalizations were a bit longer. ICU admissions were much greater, or almost a threefold incidence over that. But the outcomes really were no difference, and neurosurgical intervention was zero across the board. Again, a very important prospect. So one of the things that we're kind of tagging along right now, and what we want to do in our what we are planning right now is looking at the ability of even the level 3 centers of handling the minor brain injuries or the big one criteria patients without forwarding them to the level 1 or the level 2 centers. And our hope is that at some point we can actually expand this down to even non-trauma centers that obviously have in-hospital, whether it's hospitalists or even emergency physicians, to allow for appropriate observation and monitoring of these patients. Now, one of the things that they did in this study was they updated the brain injury guidelines just a little bit, and they included several things. And one was the original brain injury guidelines did not include GCS. So there's a lot of we're looking at the data after the fact. So the updated brain injury guidelines actually give the clinicians some actually clinical variables that they can look at and immediately make a judgment on here. So mechanism of injury, all penetratings automatically sent you to the big 3 criteria. So those automatically out of the big 1 group. Intoxication was a no for the big 1. GCS was 14 to 15. If you were 12 or 13, you were automatically a big 2, and obviously that changes your disposition in this setting. The presence of radiologic findings for big 1, again, were relatively tiny or small findings, but not negative findings. And then the therapeutic plan for these big 1 criteria were observation, 6 hours, no neurosurgical consultation, and the ability, based on your quote, impression, whether you wanted to perform a repeat CT scan or not. But these patients were now being managed at the level 3 centers. And I believe there were 2 level 3 centers in this study here. So here the patients transferred to the level 1 center in that study, looking again at the outcomes here. The big 1 updated versus the original. The outcomes, again, not showing any statistical difference here. Some of the numbers look like they're significant, but the overall numbers of the patient population in the study were fairly limited. So the statistical value here was really not present, didn't show clinical differences in these groups. So again, their findings are the majority of minor brain injuries do not require neurosurgical consultation, and likely they don't require a level 1 or level 2 transfer. And again, following particularly the brain injury guidelines, which is again a combination of both some clinical evaluation as well as a quantitative radiologic evaluation with these patients. And again, the MTAC is looking forward to this, and we are looking right now at another retrospective study. We're doing that currently at this time to look at, again, the big one criteria, and then planning on making this a prospective intervention throughout the region. So are we done yet here with these patients that essentially have a bump on the head? So what about the patients, those patients who don't even have any findings on the CT scan? We get occasionally some calls on those patients that, hey, this guy's still having a little nausea, still having a little vomiting. Do we need to transfer this patient? You know, these are the typical post-concussive symptoms here. You know, headache, fatigue, memory loss, some dizziness. Some of these things are going to be persistent for a while, weeks to even some months in these patients, and will require some medical follow-up. And it's important that that follow-up are with physicians who have some experience here and can understand what these issues are and address them appropriately. And one of the things that I have found over the years, which I think is really challenging, particularly for us, is the cognitive impairment. And, you know, I recall as a young faculty interviewing a patient that was following up for some other injuries long-term, and he had actually lost his job. And the reason why he lost his job, because he couldn't perform well. And his performance was basically the cognitive impairment. So these are patients who can have a conversation with you. They can remember where they were. They can talk about their family. They can talk about their hobbies, etc. But when they have those, what we call executive functions, where they have to make some decision making and complex interactions with facts and data and problem solving, that can be impaired. And that can be very difficult and challenging to follow up. And part of that is what our role is to make sure that these things are not lost in the fray as these patients overall look good. So again, these aren't the trauma patients that give you a lot of you know, oh, I remember this case. He had 3 operations, a thoracotomy, 3 chest tubes, and was in the ICU. This is the minor brain injury that may have a life-altering brain injury here that we really need to screen and be appropriate on. So this is really a situational awareness for us to make sure that we follow these patients and identify these patients, particularly in follow-up. So any patient with a minor brain injury will really need some level of follow-up, and preferably with someone who can understands what goes on with a concussion. So concussion screening is not always so obvious. You have to do the screen to identify. It's very much like when you do a history and physical, and you have to do the review. To do a review of systems, you actually have to ask the questions. You have to ask them, do you have this? Do you have that? And those are decisions that we're going to make that'll impact the return to school or return to work. And what we don't want to do is have people return to school or work and fail because we failed them. This is the acute concussion evaluation we have in our clinic right here. If anybody wants any copies of this, we can make this available for you. But very important that these patients truly have a screen here. And that follow-up is referral, whether it's neurosurgery or neurology. Our rehab and our traumatic brain injury in our rehab has been very excellent. Primary care, the question there is going to be the capabilities of their primary care provider to do that. In other settings, a lot of the schools now have school contacts, particularly for the sporting events, football, etc. Work, you know, their HR or workman's comp that should be involved in these cases should also be involved and give you a resource for appropriate follow-up in these patients. So in summary, mild traumatic brain injury, again, is not a great big light. It's not one that we're going to remember day to day, but it's a big problem and affects many of our patients. Neurosurgical intervention here is uncommon, and therefore we may minimize this, but we really need to be very focused, and again have a high level of suspicion for these patients. The brain injury guidelines are helpful for triage and cost containment. That is expanding. We are going to be probably pretty aggressive if our next retrospective look at this is what our hypothesis is, that these patients do not need to come here. Concussion screening is very important, and again, another important aspect of making sure these patients have some level of follow-up, and then again, establishment of appropriate management strategies for downstream treatment. And as a trauma surgeon, I don't do concussions. I don't do rehab. I got to make sure I get these people to who can help them. So just right out of the resource manual for the optimal care of the injured patient, the right patient, right place, right time. That means that many of these patients don't need to come to the trauma center, but they do need to get appropriate help. I'd like to thank everybody for listening in, and I will take any questions if anyone has one right now. I see a couple names, sorry, I don't see any hands though. All right, I see Dr. Christmas out there.
Yeah, Ron, excellent talk as always. And I think this is, this is a very important topic, especially as the, what I would call our anchoring centers throughout the country, especially the level 1 centers, as we try and really strengthen all of our trauma systems, and I know you mentioned the work by Bilal Joseph, who is another terrific physician, great friend on a national level, and everything they've been doing out there. And that's always the question is, what can we do to improve care for the community? And then realizing that our trauma centers are the quaternary, tertiary referral centers, how do we best address capacity issues? And I really think that is, that this is one of those keys, especially using the big criteria and who can be managed, out at facilities that are comfortable helping to take care of these patients. The question I have for you, and really is the one that we all have around the country, is how do we really get to that point where we understand that our providers are comfortable in taking care of these patients, realizing that the odds of this head injury progressing are extremely low, and that they actually have the resources and capabilities to care for them?
Well, I think one of the things as we move forward in design issues is obviously that this has to be a performance improvement project from the outset. So we can't just say we're going to start doing this and let us know if you have any problems. Now we have to do this. We have to do this in a way that we capture basically 100% of these patients. Now, the patients who come here are going to be easy to capture. We capture them all the time. It's the patients who don't come here are the ones that will be a challenge for us, that we make sure that we have some mechanism of doing that. My hope right now is the goal would be to have this built into the electronic medical record. So along with that, one of the things to help people not only just understand is we just can't tell them, no, we're not taking this patient, doesn't need to come here. We really have to have a process for them to follow. So we can basically give them, with a little education, what they need to do to manage these patients without transferring them. So again, instead of saying, hey, you guys just need to keep these guys, so let us know if you have a problem. It is, no, we are not, this patient doesn't need to come here. Click on the follow the minor brain injury or the brain injury guideline #1 metric or process and start that. So that order set is automatically done, and that order set should have obviously pretty clear instructions. And if that goes through a order set, particularly of an electronic medical record, then we should actually have obviously a paper trail or an electronic record trail to find those patients and find out how they were, and make sure that that the guideline was appropriate. So, for example, 6 hours of of observation. So what happens in that 6 hours observation? I would argue you probably need to have at least 3 vital signs and 3 neurologic examinations into that process prior to allowing that patient to go home from that. So again, I think it's important for us to have all of that in place for programs that are not used to taking care of these patients to begin to take care of those patients. And then obviously the default at any time is, hey, if there's any questions or any default, return a call. Our responses are very, very rapid with this. So I think that part of this is going to be some education, and part of this is going to have the processes in place for the outlying institutions, particularly the non-trauma centers, which is, I believe, our ultimate goal to keep these patients out there. Kind of alluding to one of your other issues, which I think is going to be challenging, is what do we do with these post concussive patients? That gets a bit more challenged because we have a fairly large rack. Our area goes 100 miles in one direction, and many of these areas are very rural, and their access to this kind of help currently is not free, for one, and it becomes difficult for them if they have to commute for it as well. So I think that to me is really an interesting is going to be our interesting challenge, and I suspect the challenge for that, the solution for that, is going to have to be education of primary care providers to participate in that sort of rehab. I don't see any other hands out there. Any other questions right now? Again, this is a much more voluminous problem, but again, it doesn't quite get your attention like the gunshot wound to the chest. But I think it does become a problem for us and our communities that we really need to be able to deal with, particularly from a system perspective, not necessarily from an institutional perspective. Scott, got any questions?
No, I think the biggest thing is just making other hospitals aware of the resources that are available, whether it be immediately or down the road.
Well, I hope, as I said, we are currently investigating this, kind of repeating our neurosurgical consultation paper from a number of years ago. Right now, looking at these big criteria this summer. Once we get that data back, we'll report back to the MTAC itself as well. I think our goal is at that point to begin to implement a process of keeping patients out at those institutions, particularly for the big one criteria, and implementing a process that they have the ability to care for these patients and then arrange for appropriate follow-up. So if there are no other questions, I guess we'll sign off here. Everyone knows how to find me, so if there's any questions, please email me. Otherwise, thank everyone. I'd like to thank everyone for their attention. Have a great day.